Hello, this is Dr. Kim Jongjol. Today, I will lecture on dental causes as part 3 of the causative factors of malocclusion. Items to be evaluated for dental origin are tooth number, tooth size, and tooth shape. In the previous lecture, I lectured environmental factors among the causative factors of malocclusion. This lecture is about dental origin, tooth number, tooth size, tooth shape. Position of the tooth from the occlusal plane, the mesial inclination of the tooth from the side, and the buccolingual torque of the tooth from the anterior view. First is the number of the teeth. If the number of teeth is large, it is called supernumerary teeth, and if it is small, it is called congenital missing teeth. When supernumerary teeth are located in the central incisor of the maxilla, they are called mesiodonts. Mesiodonts may be erupting or unimpacted. The impacted supernumerary teeth is hard to observe on the panorama, so it is recommended to take an intraoral X-ray. In this patient, the upper and lower central incisors have already erupted, and the lateral incisors have not erupted yet. The root apex of the maxillary central incisors is not closed yet. Supernumerary teeth are observed on an intraoral X-ray picture. Should we extract this tooth now? Or can we extract this tooth later? If this tooth does not affect the central incisor root, it is okay to extract the tooth after the central incisor root is completed. In addition to the central incisors, supernumerary teeth are also observed around canines and wisdom teeth. Depending on the location, malocclusion may or may not occur. Next is the congenital missing teeth. The first and most frequent congenital missing teeth are the second premolar of the mandible. The second is the mandibular lateral incisor, the third is the second premolar of the maxilla, and the fourth is the lateral incisor of the maxilla. There are various forms of malocclusion depending on the occurrence of the congenital missing teeth. This patient had an anterior crossbite due to a missing in the maxillary lateral incisor. If patient have congenital missing teeth, you must decide whether to close the space or to implant with a space opening. This requires a treatment plan based on various factors such as protrusive lip, acceptable profile, crowding, class 2 or class 3 malocclusion. Next is the size of the teeth. In general, there is no significant association between the size of the tooth and malocclusion. In other words, a large tooth size does not cause crowding, and a small tooth size does not cause spacing. Because the teeth are arranged in a given skeleton of each patient, I look carefully at the size of the maxillary central incisor. The normal size of the maxillary central incisor is 8.285 mm. If the maxillary central incisor size is more than 9 mm, the possibility of crowding in the anterior teeth increases. In some patients, the size of the maxillary central incisor is as small as 7.5 mm. This increases the likelihood of spacing in the anterior teeth. If the size of the maxillary central incisor is more than 9 mm during mixed dentition, it can be a guideline for serial extraction because the size of other erupting teeth can also be large. Measure the anterior Bolton ratio in the evaluation of tooth size. This is done by measuring the sum of the 6 maxillary incisors and the 6 incisors of the mandible, dividing the sum of the 6 mandibular incisors by the sum of the 6 maxillary incisors, then multiply 100. The normal value is 77.2. If the anterior Bolton ratio is greater than 77.2, it means that the maxillary incisor size is small or the mandibular incisor size is large. If the anterior Bolton ratio is less than 77.2, it means that the maxillary anterior size is large or the mandibular anterior size is small. Overall ratio is a ratio of the total tooth size, and 91.3 is a normal value. I evaluate anterior Bolton ratio more carefully, because I usually evaluate the anterior teeth condition after adjusting the canine relationship to class 1. These days, there are relatively many patients with small maxillary lateral incisors. And at this time, the anterior Bolton ratio is greater than 77.2. At this time, overbite or overjet may become shallow. Crowding may occur in the mandibular anterior tooth, or spacing may occur in the maxillary anterior tooth. It differs according to class 1, 2, and 3 malocclusion. In the case of class 1, there is a high possibility of spacing in the maxillary central incisor. And in the case of class 2, there are worse class 2 relationship due to the mesial angulation of maxillary canine. In the case of class 3, the forward movement of the mandible occurs due to shallow overjet and overbite, which may worsen the class 3 relationship. If the anterior Bolton ratio is less than 77.2, the phenomena that appear may be severe crowding of the maxillary anterior teeth, spacing on the mandibular anterior teeth, or excessive overbite or overjet in some patients. Let's look at a case. There is crowding in the maxillary, and very little crowding in the mandible. The anterior Bolton ratio is 71.5. When I calculated it, it was found that the maxillary was 2 mm larger per side. This means that reproximation of the maxillary incisors is required later. Next is the shape of the teeth. The shape of the teeth observes the shape of teeth, shovel teeth, and crowns that are morphologically abnormal. For teeth with morphological abnormalities, the lingual cusp of 12 tooth may be abnormal. Peg lateral, fusion teeth, or an abnormal shape of the mandibular second premolar, as shown in the picture. If the mandibular second premolar is abnormal, it may be difficult to obtain a proper occlusal relationship. Shovel tooth has a scoop-shaped lingual surface of the maxillary incisor. Looking at the pictures, you can see that the maxillary incisors are shovel teeth and not. The mandibular central incisor touches the lingual side of the maxillary central incisor, and the mandibular lateral incisor is strengthened by the shovel shape of the lingual ridge of the maxillary central incisor, causing crowding of the mandibular anterior teeth, which may recur after correction. Next is the crown shape. The crown shape can be divided into 3 types: square, ovoid, and triangular shape. Square shape is best, triangular shape is not good. If the crown shape is triangular, the central incisors become point contact, and the possibility of black triangles after correction increases. This is because the distance from the alveolar bone to the point contact becomes longer. If the distance from the alveolar bone to the point contact is more than 5 mm, it is called a black triangle or an open gingival embrasure. and there is a black space between the teeth and the teeth. The black triangle may get worse if you treat of premolar extraction. Tapered crown morphology is often observed in high-angle or protrusive patients. Please be sure to notify the possibility of black triangle before performing premolar extraction treatment in adult orthodontics. Today, among the causative factors of malocclusion, tooth number, tooth size, and tooth shape were investigated as dental origin. Next time, we will look at the position of teeth, mesiodistal angulation of teeth, and labiolingual inclination of teeth. Thank you for watching.